Podcast, Volume 1, the introduction. This episode, if you will, or this introduction is about who I am and what the intent is with this podcast. So for those of you that are completely unfamiliar that are tuning in here, my name is Matt Barber. I'm an orthopedic surgeon specializing in joint replacement of the knee and hip. All of us train in all aspects of orthopedic surgery during residency. Most folks at this point do fellowships afterwards to specialize in a particular discipline. That's what I did. And now I am a practicing surgeon for the last 12 years, doing knee replacement and hip replacement. And I am obsessed with all aspects of those two things. And what do we do and how do we get better? And the idea behind this podcast is what would happen if we were real, if we just told the truth, if we talked about things as I see them, and shed some light for patients and for families and for surgeons and for people in the industry. And we want to keep it real. Now, I certainly do not have a monopoly on the truth. You will have very bright and reasonable people who will disagree with me. But what if we got some information out about some of these topics and we talked about things? Because we certainly hear a lot of myths about care. We have a lot of promotion, a lot of marketing around devices, around surgeries, around something that is very personal and very important to people. And so how much can we cut through that clutter, or at least give people sources of information? And if I'm not a great source, if I can point them to other places where they can get more real information and real truth, I feel like we would have really moved the needle for some people if we could do that. And we're just going to talk about things that are interesting to me. Technologies in orthopedics, in joint replacement. This has been exploding in the last few years. Additives manufacturing, artificial intelligence, robotics, 3D printing, technologies that are based around MRIs and CT scans and three-dimensional imaging, accelerated rehab protocols, outpatient surgery, things that are hot topics that we can give people some context on and help them learn about. That's really the intent here, is to keep it real. We're going to talk to a lot of exciting guests, I think. We're going to talk with surgeons that are thought leaders around the country and around the world, that are really on the leading edge of what they do, that have strong opinions about things and about how things should be, and will bring us unique ideas. We hope to talk to some patients, to people that have been on the receiving end of surgeries, and what are we doing well and what are we not doing well, and how do we get better. We want to talk to people involved in the delivery of health care, how that looks as a system. Again, where are we falling down? I think people have a lot of sense that can be better, and we want to talk about what those ideas are and what that might look like. We can delve into history of orthopedics, of orthopedic surgery, of joint replacement. That's a topic near and dear to me, because I have to know where we've come from and what's been tried, and that gives us insight about where we're going. And so things that are interesting to me, I hope will be interesting to other people. We can talk about hot topics in orthopedic surgery. We can try to educate and inform. In terms of history, we certainly stand on the shoulders of giants in terms of orthopedic care and orthopedic surgery, going back really over a century, but certainly in joint replacement circles, things really took off in the 1960s with Dr. John Charnley and the advent of hip replacement, soon followed by knee replacement surgery, and the evolving technologies that we've seen over the last several decades. We've had wonderful surgeons over the last few decades who have trained many of us and taught us and given us a knowledge base to work from to try to grow and get better in what we do. And we want to honor that history, and we want to incorporate that into what we're doing and into how we think about the future. So I'm hopeful that you will join us in this journey, set aside some time and be part of this with us, and help us to keep it real in orthopedics here at the Ortho Real podcast. Here's some snippets of what's to come. Yeah, and I think that sort of the overarching concepts you're speaking to are exactly what you said before, which is that happy knee is one that extends and flexes easily, but has a great deal of stability. It's that goal of ligament isometry, and I really, honestly, I believe that whether it's custom implants or robotics or kinematic alignment or really any of these things are driven by that stability, by the ligament
Correct.
isometry, where we're not having condylar lift off, where we have very smooth contact throughout that range of motion, and it's not tensioning the soft tissues in an aberrant way when people walk or stair climb or things like that.
Mm-hmm.
I think we're trying to be the least wrong, if you will, as far as...
Yeah, exactly. I would agree with that, yeah.
So, great thoughts on that, and I appreciate you sharing that. You've had some publications about knee replacement and hip replacement in 10 pills or less, opioid sparing surgery. Direct this to patients and to the medical community and everybody. Why would we want to do that? And tell me about that.
Well, if you're an employer or a commercial payer or CMS, there's data out there, I think it's from CASTLIGHT, CSTLIGHT, showing that the typical commercial payer patient costs them about $10,000 a year. So, if their premium is $17,000 for the year, they're making a $7,000 profit on that person that they can then use to an outlier, right? Where if you look, if you're an opioid addicted patient, you cost $19,000 plus, so almost double the cost, and now you lose money on that patient. So first of all, opioid addiction has a direct cost to insurers and to employers, as well as to that personal family that now has to deal with this problem, and whether or not that person loses their job ultimately. So opioid addiction it's for real. So I realize that the pandemic has killed any press on this, but it is a real problem in every community in the country. Do you agree?
I think you're exactly right, and the internet and these social media platforms that we have available have really democratized a lot of information and let some of these stories get out there, and some of this information that, as you said, would have been siloed within particular companies or kind of locked down is getting out there to people that are passionate and that are interested, like me, that'll sit in their car and listen to another surgeon talk about whatever for really as long as they will.
Right.
So that's been awesome. What else? What do you see as the future in orthopedics and joint replacement in podcasting? Any of it?
I think the digital platform is going to continue to expand in terms of its importance, especially with COVID. I think some of the companies may have shut down their social media policies a little early because now this platform is becoming more and more critical. And as long as you're exhibiting some common sense, I think you should be allowed to share whatever you need to share on social media. There's been a deafening silence on some of that, with a lot of the companies changing how their reps could communicate on social media. I think that has not been a positive thing, because there's a lot of people's voices that I would like to hear. So despite that, I feel like the medium is going forward. LinkedIn has really been transforming into an amazing platform. Surgeons are taking advantage of, reps are taking advantage of, and just to get that information out. And then the podcasting is just continuing to grow. I'm seeing more and more people coming on board. I've actually thought about doing a Doc Social course on the equipment side and the Audacity side, and little tricks that I've learned on how to get the best sound and questions and all that. And I think a rising tide floats all ships. I think more people out there doing it, more people being engaged. It's just a good thing for the entire medium. So,
Dr. Whiteside, I think as we look back to the 19th century, there were a lot of attempts at some various interposition arthroplasties. In the early 20th century, the Judet brothers, Dr. Smith Peterson, some others, did some ceramic and glass and bakelite type femoral head hemiarthroplasties. But in the modern era, I think at least of maybe 1950s and onward, where we really started to get some of the predecessors of our more modern implants in the knee and hip. Think about Austin Moore for hip, Thompson for hip, and then some of the early knee designs. What can you tell us about the history of these joint replacement implants, or where you see it kind of starting for hip and knee in a more modern context?
Well, I think most people point to John Charnley's effort to cement the hip in as the beginning of the modern era of arthroplasty. But I'll tell you something. I think the cemented total hip was a huge misstep. The Ling hip and McKee Farrar and others were making some real headway with cementless fixation of metal to bone with bone ingrowth back in the 1950s and 60s. And cement sort of blew all that away. It for one thing, it was a huge marketing effort. And John Charnley was one of the best marketers in the history of medicine. People found it very easy to get on board with that guy. And he had the entire British Isles behind this effort, too. Most people don't realize what an effort it was to get him to Wrightington, to get him up and rolling, and all the facilities in place to generate this cemented hip movement. And then, of course, it went directly into cemented total knee, and it took us decades to get away from cemented total hip.
In hearing about your practice, I mean, that is exactly what comes to mind, is this model of direct primary care, which I don't know if the audience is entirely familiar with that, but is sort of an offshoot, if you will, of that concierge type care, particularly in primary care, where somebody pays basically a retainer amount to a physician, and they take care of them for the year on a cash basis. And obviously an internist armed with a lot of knowledge and a few good lab studies can take care of a ton of stuff for a patient on a pretty low cost basis. I've always been intrigued with this idea of how this translates to really not just orthopedics, but anything surgical, where you've got hospitals and ambulatory surgery centers and things involved, and sometimes implants. And was there anybody else doing anything similar, or any kind of model you went from, or did you just jump in this thing?
No, yes and no. The only models I had were based on primary care, so there wasn't any orthopedic model. I had to figure out everything from scratch. Like, what does this look like for the specialty? And just to kind of, I think something that I find confusing that's good to clear up is the difference between, so you're right, direct primary care doctors, the basic idea is a patient says, hey, let me pay you $100 a month or whatever it is. And the direct primary care doctor says, that's great. I don't take any insurance. You can come see me as much as you want. You can get labs at cost. You can get medications at cost. They have a lower patient panel. They can call and text their doctor. To me, I think it's better medical care. And usually the doctor is much happier, right? They're not dealing with insurance or hospitals or anything. And the patient is too. So that's kind of your direct primary care world. And that's been around since probably 2010, and that's been expanding. Concierge medicine, which kind of people conflate the two, is really when you have an insurance-based practice. And then you bill the patient on top of that, meaning that you bill them for insurance and you say, hey, if you want extra access to me, it's, $1,000 a year or $2,000. They tend to be more expensive. But it's a subtlety there. And, when you talk about concierge, you think of like high society type stuff. In direct primary care, there's a lot of small business owners or people that don't have insurance, and it ends up being a really excellent option for them to get high quality medical care.